me go ahead and introduce our speaker, Dr. Jennifer Matthews. Dr. Matthews is an integrative pediatrician with the Division of Pediatric Pain, Palliative Care, and Integrative Medicine at UCSF Benioff Children's Hospital, Oakland, and the Associate Director of Education for the UCSF Osher Center for Integrative Health. She works both inpatient and outpatient with children and teens with chronic and acute pain conditions. She's trained in acupuncture, passionate about herbal medicines, and focuses on integrative health equity and bringing holistic healing practices to all patients. Please join me in welcoming Dr. Jen Matthews.
Good morning. I had a whole exercise we were going to do together. Now I'm realizing everybody's sitting eating breakfast, so that might not be quite as appropriate, but I am still going to invite us to just arrive to the space together. I know that when I show up for talks, I'm often thinking kind of about all the other things that I should be doing. So if it feels good for you, invitation to just kind of notice your body in the chair, notice your breath, and let yourself arrive. And if it feels good, just a few shoulder rolls. Great. Other direction. Say good morning to the body. Perfect. Yep, people, I can see it. You already are getting your heads involved. That's great. Couple of head rolls. Just a couple nice, big, deep breaths. Right now it's spring, as you all know, and spring in Chinese medicine is the liver. So the organs in Chinese medicine have a bunch of different associations. One of those is the seasons. And right now spring is the liver, and this is Chinese medicine liver, not Western liver. And the liver in Chinese medicine is responsible for many things. One of them is storing blood, but it's also responsible for circulating qi and blood in the body. And so if any of you have been noticing irritation or frustration or maybe a little bit of anger, that's in Chinese medicine, our liver not helping, needing help and support to move our qi in our bodies. I'm bringing that up to help give you a little bit of an example of some of the topics we'll be talking about today. But specifically when we think about disorders of gut-brain interaction, and we're going to talk specifically about IBS today for kids. One of the potential diagnoses from a Chinese medicine lens might be liver qi stagnation. So that would be something we'd think about in terms of how we would go about treating this patient with acutherapy and potentially herbs and some other things. So just wanted to start us with that. So this morning, I would like to walk us through the Rome 4 framework and how this framework it really has helped us shift our terminology around how we talk about, and I think therefore how we think about kids with disorders of gut-brain interaction. We're going to talk about the importance of talking about pain neuroscience education from the very first clinic visit for patients and how important that is. We're going to talk about integrative approaches for treating pediatric gastrointestinal complaints. And we don't have time to talk about everything, but I'm going to touch on some mind-body modalities, some common herbs and supplements, and potential dietary changes. So let's start with the case. You're in clinic, and you have a 13-year-old female with a complaint of chronic abdominal pain, and she's been feeling a bit worse. So the abdominal pain's been there for about 6 months. She doesn't have nausea or vomiting, but sometimes feels indigestion. She tends to be constipated and gets full very quickly. She describes the pain as crampy, it's periumbilical, and it's always there, but it can flare and be up to a 10 out of 10, and that's where she's at today. She's tried a few different things. She's working with the pediatric gastroenterologists as well, and she's tried lactase, benefibromirax, and tried a dairy elimination for 2 weeks. When you look at her chart, you can see she had anxiety and chest pain 9 months ago, and the notes indicate she had CBT, which improved the symptoms. She's had a hard time sleeping because of the pain. She's feeling pretty depressed and has missed a lot of school over the past 2 months due to pain. The good news is her weight looks good, her vitals look good. There's no blood in the stool or fevers, so those red flag symptoms we think about. And then she's had a really beautiful workup. She's had labs, stool testing, imaging, and endoscopy, and everything looks good. So the question is, now what? So Rome 4 is a nonprofit organization that helps us think about, for both adults and children, what has been classically called functional abdominal pain disorder. And with Rome 4, which I think was published in about 2016, really helped us move to this idea of thinking about this disorder of gut-brain interaction, which is a much more, it's a diagnosis and terminology that I think is much more helpful for us as practitioners, because it helps us remember what is happening in the body, right? So functional abdominal pain disorder, and we have things like functional neurological disorder, but I think historically has been used obviously to describe kids with these sorts of symptoms, but often can be used almost as a dismissive diagnosis. I think a lot of us still use functional abdominal pain disorder as a terminology, just from it being a term that's been used for so long. But the invitation with the Rome 4 criteria is really to switch to thinking about this and talking about it as a disorder of gut-brain interaction. So the differences are thinking about the 4 subclassifications, and again, we're not going to get into all that today, of DGBI. And the nice thing about this is it really allows the practitioner to decide if, after going through things and thinking about if there's red flag symptoms, or concerns on testing or endoscopy, whether you need to do more testing or testing at all. And understanding as well that you may have DGBI with other medical conditions, or you may have multiple DGBIs at the same time. A classic example of this is a kid with IBD who's been doing really well and comes in and has new symptoms, and we're not sure, is this an IBD flare? And everything looks good, and we realize this is probably IBS. So IBD and IBS are very commonly associated and happening for kids at the same time. So again, moving us through thinking about the Rome 4 criteria, the thought is that after they've had evaluation, that symptoms cannot be fully explained by another medical condition. And again, kind of walking us through thinking about if there are alarm features to really go through with the workup, and if not, potentially thinking about, this is a diagnosis of DGBI. So I'd like to focus on IBS today, and this would fall under the bowel disorder subclassification. And the criteria, when we think about IBS, there's a few different types. So there's IBS constipation or diarrhea, and this is really thinking about, if we're looking at the Bristol stool chart, what types of stools are they having, most of the time. But then there's also IBS mix or IBS unclassified. And so for pediatric and adolescent patients up to the age of 18 for a diagnosis of IBS, we're thinking about the fact that they've had symptoms, abdominal pain, 4 days per month for at least 2 months. And this is associated with changes in defecation, and that does not get better if you resolve their constipation. So if there's treatment and their abdominal pain gets better, then we would think about that being more like functional constipation. Again, thinking about IBS, just giving us kind of a global perspective. I think there's a lot of information on the slide, but the thing that I think is interesting is that the global prevalence of IBS is about 13% for kids. So it's very common. And when we think about risk factors for the development of IBS or diagnosis of IBS, we have all these things that we can think about. So female sex, a preceding gastroenteritis, and this is something I think about when I talk with kids in clinic and kind of go back into the history, and they often will say, I thought I just had the stomach flu, but that it seems like my symptoms just never quite got better. History of trauma and abuse, lifetime stress. And I think about these kind of other buckets here, trauma and abuse, lifetime stress, psychological disorders, increased somatic symptoms, and poor self-reported sleep is kind of these vulnerabilities of the nervous system, essentially, that can set people up if they get, kind of the thing that tips them over. So when we think about kind of gut-brain disorders in general and IBS, there's, our understanding of this has really changed, I'd say, in the past 10 years with our understanding of the microbiome. And we have been talking about the gut-brain axis, but really it's the microbiome gut-brain axis. So this, again, I think invitation in terms of terminology to understand the complexity and the richness of all the different parts that may be involved with why someone's having symptoms. But we think about an underlying potential genetic predisposition. We think about things that may have happened in early life. So that may be things that are kind of psychosocially based. That might be early antibiotic use. There's a lot of different things that might be sensitizing early life events. And so those would be psychosocial or medical events here, kind of encapsulating this kid as they move through time. And then we think about, on the yellow box here over on the end, this presentation of these different symptoms and phenomena that happen with disorders of gut-brain interaction, including hypervigilance, sensitization, which we'll talk about, this disordered microbiota, gut-brain axis, and hypersensitivity and dysmotility or motility issues. So when I was a resident, I realized I did not understand pain, and I think I thought I understood pain, but I was taught that chronic pain was pain that lasted longer than 3 months, which is not true. We all know that now, that it's not a time-related phenomena per se, but it's when tissue is healed essentially and we continue to have pain. But more specifically, when we think about chronic pain and we think about the term centralized sensitization, that helps us think about this concept of nociplastic pain. And that is where there are changes in the brain and in the central nervous system. So there is neuroplasticity that has unfortunately gone in a maladaptive direction. And there is rewiring in the brain. So there may be decreased ability to decrease pain signals. So there can be amplification or the lack of ability to turn off the signal. But really, nociplastic pain is this first bullet. It's persistent or recurring pain that cannot be fully explained by tissue damage or neuropathy. And the second bullet, the take home, is this is due to changes in the brain. So when you're seeing a kid with chronic abdominal pain or these other primary pain syndromes like migraine headaches and things, this is really what we need to be thinking about, is what has been happening for this patient in their central nervous system. And it's so common when you see these kids with like juvenile fibromyalgia or these other chronic pain conditions, they have these associated symptoms such as fatigue, or kids will describe brain fog and these other things. Okay, so let's make sure we get to talking about integrative approaches to disorders of gut-brain interaction now that we've hopefully set the stage of what are we talking about. And I've listed kind of like everything, but the kitchen sink sort of thing on this slide. And this is not like, so you would go do this with every single patient, right? But I think about this in terms of a menu or buckets or tools that you may be thinking about with a patient. But every time, every patient's different, their needs are different, what they'll respond to is different. So really thinking, I think, shared decision-making and patient-centered care of what's the best treatment plan for this patient. But starting us out, always thinking about fundamentals, right? So chronic pain does not get better until you get back to your life. So it's not the other way around. Let's get your pain better, and then you can get back to your life. And this is a very hard concept to convince someone of when they can't get out of bed or they can't go to school, and you're telling them, your pain's not better, but we need you to start doing some of these things. But the fundamentals are really important. So thinking about, are they sleeping? Are they eating? Are they moving their bodies? Do they need to work with a physical therapist? The answer most likely in chronic pain is yes. And are they connecting with people, right? So are they socializing with peers or family members? So I always start there before getting into other things. We might be using herbs or supplements or medications in addition, but the focus for the patient really is on the fundamentals. We can see the other things listed here: mind-body modalities, whole systems medicines, language and education, and that might feel funny, like, why is that on this slide? We're going to talk about it. Manual therapies, music, arts, nutrition, and food. And looking at this in terms of what is there, I'm sure some of you would say, well, I would put this in this section, and 100%. This is just to offer us kind of a visualization of some of the things that we might use. What is integrative medicine? A definition, this is offered through the University of Arizona, which has great integrative medicine training offerings. But integrative medicine is healing-oriented medicine that takes account of the whole person, including all aspects of lifestyle. It emphasizes that the therapeutic relationship between practitioner and patient is informed by evidence and makes use of all appropriate therapies. And that, to me, that's just good medicine. I don't know why it's like a special definition. I think we'd all say, yes, let's hope that's what we're doing with folks. When we think about chronic pain, I know we're all very familiar with the biopsychosocial model. So this is not to say, have you heard of the biopsychosocial model? But to really house us in the idea that we have to be in the biopsychosocial model. And when we're doing, I think, anything, but especially pain management. And I have a star on the blue box for bio because we like to live there. It's a lot easier to live in the blue bottle. The problem is it's only 1/3 of a patient's experience, right? And how they move through the world. And so really important that we think about psych and social for the biopsychosocial in addition to really help promote true healing. What we know is when we combine pharmacologic and integrative non-pharmacologic therapies, we can decrease related adverse effects. We improve acute pain symptoms and emotional well-being. And there's also data that shows you decrease things like opioid use as well. And the problem is when we reach for what people might be calling complementary or alternative therapies, after we've gone through maybe lots of medications, the family gets the message, well, nothing else has worked, so maybe we can try this. And that in itself is a message to the family. So again, talking about chronic pain early with families, and I want to acknowledge sometimes we're not totally sure what's going on with the patient, right? You're seeing them, you're ordering things, you're trying to figure out, do they have IBD? Is this IBS? We're not totally sure, but holding that we need to be setting the stage to talk about chronic pain, because when we talk about pain neuroscience with families, we can actually change the patient's beliefs about pain, and they have an increased engagement in the biobehavioral recommendations. If we recommend CBT to a patient or PT to a patient with chronic pain, and we haven't done our job of explaining how pain works in the body and that it's in the brain and that it involves different parts of the brain, and then you recommend therapy, they think, you think I'm crazy, right? So we really have to help walk someone through how pain works in the body so that they can understand why we're recommending an integrative approach to medications. An integrative approach to pain, including things in addition to medications. I'm not going to get into the specifics per se about pain neuroscience education, but there's tons of writings on this. There's a lot of great information. There's a great paper that's called The Golden Hour, talking about pain. And I'll try to remember who the author was. I can't remember off the top of my head. But it is a wonderful short article that talks about this idea. So the thing that's tricky about kind of switching gears, if we've been just really moving through a biomedical approach with chronic pain, is that families can feel defensive or disengaged if we move and switch gears towards a more integrative approach, because they may feel like you think their kid's pain or the team thinks the pain is a result of a psychological disorder. And I often work with families that are, you can tell they're very frustrated, and the kids feel hopeless because they've had this really extensive workup and everything comes back reassuring, right? So again, as we touched on in the prior slide, some of these treatments, I'm going to ask you to work with physical therapy, I'm going to ask you to do CBT, can seem very counterintuitive for parents and kids. So it's important to really reconceptualize our understandings of pain and the treatment. So I use a lot of diagrams and metaphors to help break down complex language. I have like laminated handouts in clinic that I use with people, and then we can write on them together. I have parents taking this one, especially right here. I have parents taking pictures of this all the time. And it can be really helpful to have this again because it's normalizing. Like chronic pain is common. You're not alone, right? And these are the things that when we look at our experience of pain, these are the things that can change how our brain might be interpreting pain up here. And I'll ask them, do you feel like any of these things might be triggers or make you more sensitive to pain, right? So again, it's not tell me what triggers your pain, but this is how the brain works. Have you noticed any of these things for yourself? Okay, so switching gears a little bit and talking about mind-body approaches for IBS specifically, I'd like to touch on cognitive behavioral therapy, hypnosis, and acutherapy, but there are lots of things that fall under the umbrella for mind-body approaches. There are different thoughts to why mind-body approaches work, and one of those is that it helps turn on the parasympathetic nervous system, so it helps our vagal nerve do a better job. But we know that mind-body approaches are much more complex than that and really can be aimed at treating the gut-brain axis, the immune system, and the HPA axis as well. So CBT, again, this is gold standard for chronic pain. It can be, at least up in the Bay Area where I work, it can be hard to even just find a therapist to see kids. So finding someone who's trained in chronic pain management and does CBT can be tricky, but it can be done. And the beautiful thing about working with a CBT person is that as you're helping this kid get back to life, they're doing a variety of techniques with them, because what happens is for folks in chronic pain, and the bottom blue is emotions, depression, anger, and anxiety, is that we move through this cycle, right? So we have chronic pain. I have thoughts that might be catastrophizing. I feel hopeless. I feel helpless. I feel more anxious, depressed, and angry. And then I become more avoidant. I withdraw, and that makes my chronic pain worse. So it's really about helping break the cycle through different strategies. Hypnosis or hypnotherapy, many people have heard of this in terms of stage hypnosis, like at the fair or something like that. My children, I'm trained in pediatric hypnotherapy, and my kids saw The Incredibles 2. If you've seen that, where the villain puts hypnosis goggles on people and they're like, that's what you do? And I said, no, that's not it at all. And I bring that up just because often if I'm talking to a family about hypnotherapy, there's just a lot of misconceptions about what it is. And hypnotherapy is really a strategy that you're teaching a child to be able to do for themselves for something the child wants to be different or better. Not the parent, but the child. So you can see here the definition is saying it's spontaneously occurring or induced alternative state of awareness. We call it trance, in which an individual develops a focused concentration of an idea or an image with the purpose of maximizing potential to create change, reduce or resolve some problem. We're all in trance all the time. Some of you may be in trance right now, thinking I'm on the freeway, I'm driving home. Oh, I just missed my exit. I wasn't even paying attention, right? So we're all in these altered states of consciousness all the time. And hypnotherapy says, what if we take advantage of that and we help somebody have more tools for coping or change? I would say just briefly, what is it like? It is a strategy that you teach kids to do for themselves. It can look like guided imagery, but it's very different in that it's specific to that child. So you've gotten to know that child, what they like, what they don't like, and what they'd like to change. And then you work with them specifically for them to develop their own kind of language and imagery around it so that they can do it for themselves. And when we think about, well, why does hypnotherapy work? We know that when you're in a hypnotic state, your brain is in a very heightened state of neuroplasticity. So the capacity to change is very unique. So if you've ever heard somebody wants to stop smoking cessation, and they said, I went to one hypnotherapy session and it was gone. So these things can happen. That's not usually the case with chronic pain, but again, more of a tool that a child can use to help manage symptoms. I wanted to give you some resources. If you would like to get trained in pediatric hypnotherapy, I can talk with you more about that. But even just giving patients more resources, this website, Hypnosis for Abdominal Pain, it's both in English and Spanish, and it's, I think, 6 audio files to listen to, and it's like $30, so it's very affordable for families. And then Nerva, I would say maybe not appropriate for kids, but older teens and adults, is specifically an app that is hypnotherapy for IBS. And there's a lot of literature around hypnosis in general for children, but one of the, I would say, landmark studies was done by Ann Vlieger, and Ann Vlieger is the person that created that Hypnosis for Abdominal Pain website. And this was a paper published in 2007, so quite some time ago, but they took 2 groups of kids with either functional abdominal pain or IBS, and what do we see? You're like, I don't know, it's too small. But the top circles is standard medical treatment, and the squares are hypnotherapy. And so you can see change in time and pain intensity score, right? This is crazy. And I want to say we're going to talk about nutrition. I'm sure most of you know about low FODMAP diets, but this study also I thought was so interesting because the question is like, there's so many things to do. How do we decide what's the best thing for this patient? Well, my answer is let the patient tell you what's the best thing for them. But this is a study done with adults where they took the adults with a diagnosis of IBS and they either gave them the low FODMAP diet or they had them do hypnotherapy, and the results, both groups got better and the results essentially were the same. So then it's like, so at first I was like, oh, now what? And then I was like, oh, wait, this is great news. It means we all work a little differently and different things are going to work for different people. At least that was my takeaway. Okay. So moving from mind-body interventions to nutrition interventions. Again, this is thinking about as kind of kids move through the spectrum of life. We're focusing on the green box here for pain predominant DGBI, and we're going to just touch on a few of the different things that could potentially be helpful for kids with IBS, thinking about fiber, the low FODMAP diet, single carbohydrate elimination like fructose, enzyme supplementation like lactase, and then other diets like gluten restriction. So FODMAP, there's a lot of information there. The FODMAP diet, I do think it's very helpful. I would say I think it's very hard for kids to do FODMAP, and it's very hard for parents to get their kids to do FODMAP. It's pretty restrictive. So what I'll often do is give folks the information about the FODMAP diet and kind of look over it with them and say, let's be curious over the next few weeks and see, do you notice there's certain foods that seem to trigger more so? And maybe we can kind of cut those out. What I would say is, as you know, from working with teens especially, and kids with chronic abdominal pain often have a pretty restricted diet by the time you're seeing them. And so I'm often very hesitant to restrict them even more. And kids are really developing their sense of self, hopefully healthy body image and weight. And I'm just always really mindful and kind of thinking about, am I getting hints of disordered eating from this kid? Is a restrictive or elimination diet maybe not the right way to go for them? But just kind of holding some of these things of, could we try a little bit of elimination? Could we try switching the diet around? But I would say overall, the data shows that a FODMAP diet can be very helpful, but it should be short term, so a few weeks, with the idea that you're going to slowly reintroduce foods one at a time to see if there's a trigger. So lactose restriction, and again, I feel like when I meet families, they've already played around with cutting dairy out or cutting gluten out. Lactose and fructose are two things to think about. I think the data is a little bit mixed. You could always, test for lactose intolerance, or they could even just do a trial with lactase supplements. Fiber, though, fiber is also, I think, can be tricky to use, but I think really important, and is usually the thing that I focus on with families, because often when you do a diet history with kids and families, I'm noticing there's a room for a lot more fiber in the diet. And the studies that have been done for kids are looking at 3 different trials that showed increasing soluble fiber by over 5 grams per day showed an improvement in their pain symptoms. And we're going to talk about fiber more in the next few slides. Gluten, I still feel like there are kids that will do better off gluten, and yet I will acknowledge that the data doesn't really show that that's helpful. So again, I think thinking about it with the family. Okay, so we talked about FODMAPs. This again is just kind of reiterating that. If you can refer to a dietitian, that's so ideal. We don't have great access for a dietitian unless they're plugged in with our pediatric gastroenterology clinic. We can do that. And then I just wanted to share this resource. Monash University has a great app that can help families very quickly screen for foods with like a kind of traffic light coloring system where it's like go, stop foods. So this can be used as well if families are trying to navigate a FODMAP diet. Okay, and then touching on fiber, I think, again, really thinking about trying to get it through food is so important, and this can be a struggle for parents. So I will often kind of brainstorm with them how they can add things to food. Can they add it to yogurt? Can they add it to oatmeal? Can they add it to a smoothie? Just trying to think about, can they add it to muffins they're making? Thinking about ways to just slowly incorporate it, potentially without the kid noticing. But here are some suggestions for things that you can do that could help meet goals of getting kids getting more fiber. I tend to use ground flaxseed with making recommendations because it's it tastes pretty good, and you can put it in things and it doesn't have a pretty, not a distinct flavor. But really thinking about starting at lower doses and increasing slowly with sufficient water intake, because what can happen is if you just really, go for it with fiber, kids are like, well, now my stomach hurts even more and I don't want to take this, right? So being kind of go low and slow. That's supposed to say herbs or supplements for IBS. We could talk about a lot of different herbs and supplements. I'm going to focus on just a few today. And the nice thing is the family may not even need to buy anything, right? But we think about carminative herbs. Carminative is a drug that relieves flatulence, for the definition. But they can just make tea with herbs at home, and any of these things, whatever the kid likes the taste of, they can do this. And I usually recommend to sip it after meals because these herbs stimulate peristalsis, and they also help relax the smooth muscles of the stomach. So it can be yummy and soothing. There are different products that you can use if you wanted to use a supplement. And this is, I think most people are familiar with enteric-coated peppermint oil is like IB Guard. And there's some data that shows for kids that it can help reduce pain. So this is one of the study where they tracked peppermint oil versus placebo and looked at pain over a few days and found that there were better pain scores for kids taking peppermint oil. I would say the thing that we just need to be mindful of is that families don't just give kiddos peppermint oil, but that it really needs to be enteric coated so that it gets through the upper part of the digestive system and doesn't cause reflux. And kids can take it scheduled, TID, short term, or they can also take it as needed. Okay, Iberogast. I really like Iberogast. It's 9 different herbs. I will say it has a distinct taste, kind of licoricey. And I have found that a lot of kids come back and tell me it tasted awful. So I'm like, I always say, if you like the taste of licorice, this might be great, but just keep it in mind. And it's wonderful because it also comes as a liquid formulation. So it can be easy. The family just takes essentially, depending on the age of the kiddo, a dropper full and puts it with water or a little bit of dilute juice and can take it. And I use Iberogast. I use it especially for functional dyspepsia, so those kids that are kind of refluxy, but it continues to work down the digestive system and can be really soothing. This is a product that's made in Germany. It's used in Germany, I think much more than it's used here in the US, but it's very safe. There are a few different studies that look at Iberogast, and it is safe. I will say, because people will bring up this subject, that there's been some case reports of liver toxicity, but what I will say is it's with the isolated herb celandine, and it was at much higher doses that are not used in the Iberogast supplement. Okay, probiotics. We could have a whole lecture on probiotics, as you all know. I am going to move us through this a little bit so we have time for questions. But what we know is in IBS, what I would say is we know that there is dysbiosis, meaning there's an imbalance of the bacteria. And what we see is there's a decrease in bifidobacterium and lactobacilli in general when we look at the data. And that this dysbiosis really can lead to incorrect immune responses and have a ripple effect throughout the system. And yet, the American Gastroenterology Association has said we don't have an official recommendation because the studies are all over the place. They're using all different strains, all different doses. Like, we just can't say whether it's, it can be used officially for IBS. That being said, I use it, and I recommend using a multi-strain product, including lactobacillus, bifidobacterium, and Saccharomyces, and I usually recommend families do it for 6 to 8 weeks. And I just have a note here that With probiotics and fiber, I always recommend families implement them slowly and ramp up on the dose. But if you're noticing that kids are getting a lot worse, to think about reaching out to gastroenterology again, to think about small intestinal bacterial overgrowth, because that might be something that needs to be treated. Okay, so pharmacologic therapy, again, just want to touch on this. We're thinking about, does this patient predominantly have IBS-C or IBS-D? We might kind of go through and think about different strategies. And one of the things, I'm not going to talk about the pharmacologic agents, but you can see things like here on the left, we might be using prokinetics for IBS-C, and for IBS-D, we might be using things like antidiarrheals, bile acid binders, antispasmodics, things like that. And then as we get down to the bottom, yellow, we might be using things like pain modulators, which would be things that often kind of fall under both the antidepressant category as well as neuromodulators. Okay, so neuromodulators. This is, I think, also an area that I have just a lot of interest in, is thinking how do we target the gut-brain microbiota access with neuromodulation and neurostimulation. So really thinking about these patients often have motility issues because they have low parasympathetic tone. And then we see that they have visceral hypersensitivity, and this inflammation is kind of driving this visceral hypersensitivity as well. So if we can think about what we're targeting, we want to enhance their parasympathetic tone, lower their sympathetic tone, and get things moving, and also decrease inflammation, which will help decrease visceral hypersensitivity. So I want to, again, acknowledge that we could talk about traditional Chinese medicine as a whole system of medicine, and specifically acutherapy, for quite some time, but I am going to just touch on a few pieces today. But really thinking about traditional Chinese medicine as a treatment and whole systems medicine that we can either use as a whole system of medicine or potentially think about different strategies within the medicine to help patients. And the 5 branches include herbal therapy, diet and nutrition. We use the word acutherapy very specifically at our hospital because we work with children, and we would not use the word acupuncture with them, but we also use a lot of non-needle techniques with kids. Movement like Tai Chi, Qigong, and then manual therapies like massage. So thinking about acutherapy for gut-brain disorders, in no way am I saying acutherapy and this is just neuromodulation, but to really just speak to the, I think the historical piece of the medicine is thinking about regulating the function of qi or energy and blood to help balance the system. And we do that by stimulating acupoints to unblock or stimulate meridians and channels on the body and the associated organs. As we talked about, the liver this morning might be one of the organs involved in treatment. And what's so interesting as we think about these meridians and channels, there's really this overlap of points that interface with the nervous system and our fascia that can release endogenous opioids and neurotransmitters with stimulation. I'm going to skip this slide, but there's lots of different discussion around the mechanisms of how acupuncture works on the body. And wanted to give you a flavor for potential points for abdominal symptoms. Everyone's treatment is different and individualized, and it's a different diagnostic system that is used, but this is an example of different points that might be used. So for example, large intestine 4, which is right here on our hand. Many of you may know it for headache, but it's a wonderful point for constipation as well. And when we look at the evidence in terms of what's been, in the literature, there's a large number of studies that have looked at acupuncture being used for symptoms of IBS without adverse effects, and also thinking about acupuncture or electroacupuncture that would be using electric stimulation with the needles, and and that may be better than or equal to traditional pharmacologics for IBS. So the whole body is represented on the ear in Chinese medicine. There are microsystems in the body in Chinese medicine. The scalp, the top of the hands, the abdomen. So the body kind of shows up all over the body, but it shows up on the ear. And if you can notice this already, it's upside down, right? So the brain and the head are on the earlobe, the feet are up top. And then if we look at kind of the inside of the ear, it might be hard to see, but you can notice it says things like intestines and stomach and those sorts of things. And then if we move over to what the nerve and the innervation of the ears, what do we see is innervating that part of the ear? The vagal nerve, right? So the external representation of the vagal nerve shows up on the ear. And this is an example of some points being needled for auricular acupuncture, meaning I'm going to treat your body through treating your ear. So I use ear seeds in clinic. I use acupuncture needles in clinic. I teach people to massage their ears. There's lots of things to do that are very non-invasive. But to me, this technology is this beautiful combination of technology and ancient wisdom together to help patients. This is a device called IB-Stem. Anybody familiar with IB-Stem? So we use IB-Stem for, we use it for a lot of things, but it is FDA approved for kids. It keeps changing. It was 11 to 18, and now I think it's 9 to 18 for chronic abdominal pain. So you can see it looks somewhat like a hearing aid. It attaches with 4 leads to the ear, and it gives electric stimulation to the ear over a period of 5 days. They take it off at home and go device-free for 2 days, and we place it once a week for 4 weeks. And so there's different thoughts on how this works, but again, they're very tiny needles underneath those stickers, so it's needling the ear with the device delivering an electric current. And what I'll say is I think probably the biggest take home is that it's helping turn your vagal nerve back online. But there's also some evidence that shows when they look at the amygdala and some of these other brain structures that are involved in chronic pain, they show improvement in those areas of the brain as well. So you can see here, this slide is from 2017, and actually there's been quite a few more studies on this device, and there was recently a study on this device being used for cyclic vomiting as well. But this device in the study that is listed here showed 81% of patients had an improvement in the global symptoms scale. About 60% had greater than 30% reduction in worst pain. So again, I wouldn't necessarily just say we're just going to do IB-Stem, but this is part of an overall treatment plan potentially. And I wouldn't necessarily jump to this, but I'd be thinking about this as well. This is very hard to get covered by insurance. You have to have failed 3 different classes of medications for your insurance company to authorize it, and families can pay out of pocket, but it's about $2,000 for the 4 weeks. So mechanism, this is just talking about like, why does it work? We talked about that a little bit, but basically downstream you get increased acetylcholine release and nitrous oxide, which does really good things for your digestive system. Okay, back to our patient. So here's what we did for her. Again, we focused on foundations, lots of pain education, got her plugged in with CBT and working with a provider to learn hypnosis, slowly worked on some nutritional strategies, started her on probiotics and did a short-term melatonin bridge to get her sleeping, and then saw her for acupuncture, and during that also worked with her on learning some breathing techniques. I wanted to share some resources that I use a lot. This book over here on the right, the orange workbook, is phenomenal. It's written by Rachel Zoffness, who's a pediatric pain psychologist. It's $20 on Amazon, and I use it all the time for teenagers. I love all of these what to do when books. I don't know if anybody uses these, but what to do when you worry is great. It's short. And then this book written by Lonnie and Paul Zeltzer, Pain in Children and Young Adults, is really great. I recommend. I wish I had read it as a resident, and I recommend it for parents. And then I haven't found a great integrative peds gastroenterology like book per se, but I think this is adult focused and is a nice resource. So, and that's it. We got through it all. I can give you my email if you want it. But I think we have about hopefully 5 minutes for questions. If anybody has questions or comments or anything they want to talk about.
Thank you so much, Jennifer. That was such a great overview of integrative approach to abdominal pain. I've been practicing integrative medicine for, as I told you, like almost 18 years, and we have both a nutritionist, a coach that deals with more mental stuff, and now we have a craniosacral myofascial therapist. There are some families that are not really keen into Chinese medicine, and that's something that it's important to bring about. So many great things about other modalities. I wanted to ask you, I know we were talking about the IB stem. I know there's also vagal nerve stimulators that, do they work differently? So it's not an it's not a meridian thing, but it's actually the vagal nerve that runs through that. That's one thing. And then just any thoughts about EMDR, which is an eye movement, especially for traumas. That's one of the big things. Yeah.
I love both. Thank you for asking those questions. The external vagal nerve stimulators, I think it's the IB stem, and that is similar. I don't know of one that's approved for kids on the neck. So I've had some older for example, I've looked at some with families, like I think it's Truvaga for the neck. And so if it's a teen that's kind of close to being 18, I'm like, yeah, but it's also not covered by insurance. So I think they're probably pretty safe. When I think about how to help someone make a decision, about something, I think about ECHO. So efficacy, cost, harm, and opinion is like, what is the efficacy or evidence for this? Is there? And when we say evidence, this could be a larger conversation, right? When you're like, so is there a randomized controlled trial? And also I'm like, what about historical, ancestral, familial knowledge? Because that's really important too. So kind of thinking about that. Is how much does it cost? Is it $20 or $2,000? What's realistic for a family? Is there harm that can come from using this product or whatnot? And then opinion, what's the family's opinion and the child's opinion around it? So for the vagal nerve stimulators, I don't know is my answer to you, because I don't think we have great evidence for its use in kids. And that being said, if it's an older teen, my practice approach has been like, I think it's okay and won't hurt if you want to try it. And then your second question was EMDR. And I don't know if folks are familiar with that eye movement desensitization response. Reprocessing is fantastic if the patient is receptive to it and it's the right paradigm for them. And I think our challenge is we have maybe one person that does it, so it's access is the issue. But I have a patient who has a teen with chronic pain who has a lot of medical trauma. So even just meeting with her initially was very traumatizing for her to have to come to clinic. And she utilized EMDR and shared she found it so helpful. So thank you. Any other questions? I know we're running out of time.
There was one question in the chat asking if you had seen Munchausen's present as chronic abdominal pain.
Sure. Yes, I think that's, but it's hard, right? Because pain is the person's experience, right? So I think keeping that in mind or is there a secondary gain here or kind of other things is important. But I have found that's very unusual and unlikely, but yes. Anything else?
We're out of time, but
Okay.
thank you everyone for coming.
Thanks.
And if you're available at lunch, Dr. Matthews is going to be doing a workshop over in the residency classroom as well.
Thank you so much.